Hi, today I'm going to be talking about endocrine tumors of the pancreas. I'm going to start with some normal anatomy. The pancreas lies in the epigastrum. It lies horizontally. It can be quite hard to distinguish because of the duodenum, intestines, and stomach that lie laterally or superiorly towards it. Also, the main way that we find the pancreas is by finding our landmarks, which are the aorta, IVC, and portal splenic confluence that all lie posterior to the pancreas. We also look for the SMV that lies between the neck and the uncinate. The normal would be the head is by the duodenal loop and the tail is by the splenic hilum. So we can look for all of those to try to distinguish the pancreas. The normal echogenicity of the pancreas in adults is going to be hyperechoic or echogenic compared to the liver, and in children it should be hypoechoic to the liver. Normal measurements when taken in a transverse plane, anterior to posterior is going to be the head should be about 2 to 3 centimeters, the neck and body should be 1.5 to 2.5 centimeters, and the tail should be 1 to 2 centimeters. When we think of pancreas, we should think of two functions, which are exocrine and endocrine. The exocrine function is to aid in digestion, and the endocrine releases hormones directly into the bloodstream. Hopefully, when we think of endocrine and pancreas together, we think of the islets of Langerhans, right? Which this is the area that the cells that create and secrete the hormones. Specifically today, I'm going to refer to the islets of Langerhans as islet cells. They're the same thing. And I'm going to touch base on 3 different hormones, insulin and glucagon, which we know that those two work together to regulate sugar levels in the blood. And then I'm also going to talk about gastrin, which helps, it stimulates the gastric acid in the stomach, which helps aid in digestion. The tumors, the general definition of the tumors, and you'll find this a lot in all the different kinds of tumors I'll talk about in a bit, they arise from these islet cells when they're endocrine tumors, and they can be singular, multiple. If they're multiple, they usually are associated with MEN1, which stands for multiple endocrine neoplasm syndrome type 1, also known as Werner syndrome. This particular syndrome shows lesions not only in the pancreas, but also in the parathyroid and pituitary gland. These lesions can be singular or multiple as well. If they are malignant, then they're going to be necrotic, they might hemorrhage, and they could have calcifications. And when we're talking about endocrine tumors, there's 2 separating differences. There's either going to be non-functioning or functioning. The non-functioning means that they're not secreting any particular kind of hormone. Functioning means they're over-secreting a hormone. Non-functioning make up 33% of all islet cell neoplasms. Of those 33%, 92% are malignant, so it's a very high malignancy rate. Unfortunately, with non-functioning, they're not caught very early because they're not secreting a hormone or over-secreting any sort of hormone. So there's no symptoms until the tumors grow large enough to start affecting either the pancreas or the surrounding organs. So they're usually asymptomatic, and when they do start showing symptoms, they'll have diarrhea, indigestion, abdominal and back pain. They might have a palpable mass and jaundice. Some clinical tests associated with that. Sometimes these tumors will increase 2 hormones that don't cause symptoms, and that's the pancreatic polypeptide and the chromogranin A. You can also test bilirubin if they look jaundiced. Sonographically, they're very irregular, usually because they're malignant. They grow very large. They grow slowly, but they grow very large. They can be either hypoechoic or echogenic. So there's a lot of variation here. This is an image. It's going to be a loud noise. that shows this right here is this particular neoplasm. As you can see, it's very hypoechoic here. There's some internal echoes as well. The treatment for this particular kind is either going to be surgery to remove the tumor, or especially if it's malignant, it's going to be some sort of therapy, whether it's chemotherapy, targeted, or hormone therapy. So that's all for non-functioning. Now I'm going to talk about functioning. There's two specific kinds of tumors I'm going to talk about in more detail, and then there's a general grouping that kind of encompasses all the more rare kinds of tumors that are functioning. So a functioning islet cell tumor, like I said before, it secretes an excessive amount of hormones. In particular, the first kind I'm going to talk about is insulinoma. It's the most common functioning islet cell, and it has an overproduction of insulin. It's also known as a B-cell tumor because the insulin is produced and secreted in the beta cells, so it's known as a B-cell tumor sometimes. With this overproduction of insulin, it often causes hypoglycemia. That's the main symptom. It's also going to potentially produce a clinical triad in patients, which is where they are in their 40s to 60s. They present with hypoglycemia, and they have immediate relief after being given glucose via an IV. That's called the clinical triad that's often associated with insulinoma. These tumors are usually benign, about 10% are malignant, so not a very high malignancy rate when you have an insulinoma, which is nice. You will have typical signs and symptoms associated with hypoglycemia, so confusion, slurred speech, headaches, pallor, sweating. In extreme cases, the patient could be in a coma. That's a little more rare, but it can happen. The lab tests are usually going to be a glucagon insulin or glucose insulin fasting test. But they can also do the clinical triad test as well to check and see if they're giving glucose, if that helps them. Sonographically, they're usually very small. 1 to 2 centimeters is pretty average. They're hypoechoic or isoechoic, which makes them very difficult to find. They tend to be in either the body or tail. They can be found in the head. If they're found in the head, they're a little easier to find. They're usually found in the body or tail, though, because that's where the islet cells are most prominent, are in those two parts of the pancreas. I have a couple images. Again, it's going to be a loud noise. Here you can see, hopefully, there's calipers right there. That's showing that particular tumor. As you can see, it's very hypoechoic. It almost looks anechoic, but it's not anechoic. And then the second image that I have is going to have all the arrows, which is nice. Otherwise, it's very hard to distinguish because this particular kind is isoechoic, and it's very hard, as you can tell, to see the difference between the two, between the normal parenchyma and that particular mass. So it takes very careful scanning to find these kinds of tumors. The treatment, again, is very similar for all of these tumors. You're either going to have some sort of surgery to try to remove the tumor. If it's malignant, more than likely you're going to have chemotherapy, hormone therapy, or targeted therapy, or some other sort of treatment for cancer. The second kind of functioning cell that I'm going to talk about is gastrinoma. The gastrinoma is going to be a tumor that overproduces gastrin. It's also known as a G-cell tumor, much like insulinomas are known as B cells because of where the insulin is produced. That's the same thing with gastrinoma. Gastrin is produced in G cells, so it's known as a G-cell tumor sometimes. This kind of tumor has a much higher malignancy rate. About 60% of these tumors are going to be malignant, so it's a little bit higher, obviously, than the insulinoma, but not quite as bad as the non-functioning. With the overproduction of gastrin, the signs and symptoms of that are going to be peptic ulcers and diarrhea, and I'll come back to those two in just a second. It's also going to be throwing up blood, severe left upper quadrant pain, and potentially could have gastroesophageal reflux. So going back to the peptic ulcers and diarrhea, there's something known as the Zollinger-Ellison syndrome that's associated with this particular kind of tumor. And the three requirements of having that syndrome is that there's an increase in stomach acid, there's stomach ulcers, and there's diarrhea. So usually the gastronoma, because it's secreting gastrin, which stimulates the stomach to secrete more hydrochloric acid, gastric acid, and peptin, causes the interior lining of the stomach and intestines to eat away at itself and creates all these ulcers that often shows that syndrome as well. And the lab tests are there's several that you can do for this. There's the gastrin test, the basal acid output test, secretin, a stimulation test, and somatostatin receptor scintigraphy. So there's several that you can do for that. Sonographically, these tumors usually present as multiples. They're very often extra pancreatic, which means they're outside of the pancreas. They can even sometimes be found in the duodenum. So because they're extra pancreatic and they can be found not even on the pancreas, they can be very, very difficult to locate as well. They do grow bigger than the insulinomas, but they're still comparatively smaller than the non-functioning cells, non-functioning tumors, which get quite a bit bigger. With this, the treatment for these, usually again, it's going to be surgery or chemotherapy, hormone therapy, targeted therapy, but you might also have, in addition to this, a gastrectomy, which is partial or total removal of the stomach because there might be so many ulcers from the extra gastrin or peptin and hydrochloric acid from the extra gastrin that you have to remove the stomach. That's the only solution. And then there's let me show the image as well. Sorry, loud noise. As you can see here, they're showing the vein, and this right here is that tumor. Okay. And then there's a grouping of other tumors that they call rare islet cell tumors. And the rare islet cell tumors are lipomas, somatostatinoma, carcinoid, multihormonal, glucogonoma, and vipoma. Out of these, glucogonoma and vipoma are the most likely to be malignant. All of these are very, very rare though. But glucogonoma is going to, much like insulinoma and gastronoma, it produces too much glucagon. And basically it's going to do the exact opposite of what the insulinoma does. It's going to make the patient hyperglycemic and cause a lot of those symptoms that are similar to hyperglycemia. But again, if you have a glucogonoma tumor, it's going to pretty much be malignant. So it's a lot more dangerous than the insulinoma that only has a 10% malignancy rate. And then the vipoma, the VIP part of vipoma stands for vasoactive intestinal peptide. So much like the gastronoma dealt with the peptin of the stomach, this also deals with the peptin of the stomach, but it can cause dilation of the gallbladder, distended and fluid-filled bowel, excessive secretion of electrolytes and fluids, and a thickened stomach wall. And that one is also obviously very dangerous because it affects so many other organs. I actually have an image of it. They grow quite big and can be very hypoechoic or isoechoic. which makes it quite difficult to distinguish, but this one's a pretty good image. You can see this whole thing right there is the viapoma. And you can see that the pancreas is right here and it's enlarged. You can't really see the splenic vein or the SMV or anything there, so it's affecting a lot of the anatomy there. And my references are the Hagen Ansert, Volume 1, Temkin. I also went to the USC, University of Southern California, surgical department website, and the National Cancer Institute website, and a website called Medscape. And that is all for endocrine tumors of the pancreas. Thank you.